Hello, everyone, and thank you for joining this presentation, which is part of an online technical consultation being hosted by the Improving Maternal Health Measurement Project, focused on developing additional indicators for ending preventable maternal mortality to fill identified gaps. I'm Barbara Rawlins with JPIGO, and I'll be talking about construct number 5.1, which is related to use of data for decision making. This construct is new and untested. The proposed construct is an indicator that tracks use of maternal newborn health data by health workers for decision making. And the EPMM phase 2 formulation of the draft indicators percentage of health workers using MNCAH data for decision making. And I wanted to note actually that the formulation of the indicator is a little bit broader than the construct itself in that it includes both child health and adolescent health as part of the indicator. In terms of clarifying the construct for measurement, there are really several terms within the draft indicator that would need to be clarified, including defining health workers, specifying what types of maternal, newborn, child, adolescent health data would be collected or included as part of the measurement, and then clarifying what counts as decision making. In terms of the state of measurement with respect to this construct, this is really a new construct. There are no current related standardized indicators being used at the global or national levels that I'm aware of. The more general construct of health data use has been measured systematically in a number of low and middle income countries as part of data quality assessments. Some countries have also measured data use as part of evaluations of health information system strengthening efforts, and WHO and Measure Evaluation have developed and used tools assessing data quality. So what do we mean about data when we say data use? I mean, data use is really a process whereby we move from raw data to data that has been analyzed in such a format that it can be used for decision making. And this data information knowledge and wisdom pyramid, I think, provides a good overview of that movement from the bottom of the pyramid here, from raw data to information, to knowledge, to wisdom, and then actually applying that wisdom to inform, identify and inform specific decisions or actions that can be taken. In thinking about data use within the health system, I think this health information system pyramid is useful as it shows at the bottom of the pyramid, the most data is generated around patient care, patients and communities. There's a lot of data that is available and generated at that level. But as you move up the pyramid from the patient and community level to the facility level, a little bit less data is generated. That data is more around facility management and operational efficiency and coverage type data. And then as you move up to the district and national level, there's a little bit less data that is reported up and used, and it's the data needs are slightly different at the district level. It's around implementation of policies and resource management, whereas at the national level, there's a need for more strategic information. Our colleagues at Measure Evaluation have done a lot of thinking and work around how to measure data use, especially routine data that's part of the health information system. This diagram shows or places data review and interpretation, data-informed advocacy, and data for decision-making within this continuum, moving from sort of improving the health information system to improving health program performance, to ultimately improving health system functioning and contributing to improved health outcomes and health system outcomes. As part of this work, Measure Evaluation has developed some indicators to measure the process and outputs of data use. And here I pulled out a couple of the determinants of data use that they have identified in their report on conceptualize and measuring data use, including one determinant, engage data users and producers in, for example, data program review meetings. So here you can see they have focused on measuring data use as part of a kind of continuum And they have different levels of measurement where they're looking at different pieces of the puzzle. Measure Evaluation has also recently updated their performance of routine health information systems management framework. And here it really shows data quality and use of information as an output of a process to really assess routine health information systems, examine and improve different determinants that influence the use of data for decision making, including technical determinants, organizational determinants, and behavioral determinants, and then ultimately leading to improved health outcomes. The PRISM toolkit does include a specific assessment module that looks at the health facility level. It looks at routine health information system performance at that level. It examines continuous use of routine health information to guide day-to-day operations, track performance, learn from past results, and improve service delivery. And the tool also focuses on the use of RHIS data by health facility staff in different ways. More specifically, the toolkit has questions on the following topics for health facilities. Information use guidelines and strategic documents, data visualization, report production, feedback to health facilities, routine decision-making, and processes at the health facility, which are really important for interpreting data, annual planning, supervision by the district, and data dissemination outside the health sector. In addition to some of the work done by Measure Evaluation to look at how to conceptualize and measure data use, there are also several examples in the literature of studies in low and middle income countries that have used qualitative methods to capture how different health actors are using data for decision making. And this is an example from Botswana of health management information system officers at the district level, clarifying their achievements in the area of improving and supporting use of health data for decision making. So in reflecting on measuring this construct, I was asked to touch upon a few different areas. First of all, construct validity. And I think in general, it's not completely clear what this construct is supposed to measure, specifically with regard to MNH, and this needs more discussion. In addition, as a construct, I think use of health data, especially routine health data to inform health decisions is important. And there are linkages with improving health outcomes that had long been discussed and established. In terms of the feasibility and data availability, I think this is a little more problematic. There currently are not data that are readily available for the proposed indicator underneath this construct. And in addition to that, it may not be adequate to just have a quantitative indicator, but really a mix of qualitative and quantitative data may be useful for measuring this construct. And in addition to that, in terms of feasibility, it's not really clear if it will be affordable or feasible to collect this information in a timely manner, as it will require additional resources and additional data collection efforts. With respect to harmonization, I think this construct does have the potential to strengthen or complement existing MNCH measurement efforts, but it may be more suitable for subnational level measurement than national level use. It does not duplicate any existing indicators or measures by EPMM or WHO recommended MNCH indicators, and it is in line with WHO's current priorities and support for analysis and use of health facility data, including the RMNCAH facility data use module that they've developed. In terms of relevance, I think that this construct is directly related to and able to support EPMM strategies for reducing preventable maternal mortality. But it isn't clear, there isn't really evidence to show whether or not the indicator or the construct is really significantly associated with improved maternal health outcomes. And then in terms of interpretability and usefulness, we really need a better defined construct in order to develop actionable indicators that could be tested in different country contexts to better understand whether this could be useful or not. So overall, I would say that this is an important but broad and complex construct that doesn't really lend itself well to a single standardized national level quantitative indicator. There are key terms within the current indicator formulation that really need to be better clarified and defined, including health worker, MNCH data, and decision making. There's a need to really clearly identify what data use information is needed by which health workers at which level of the health system, and really understand who the primary audience is for the indicator or any indicator related to this construct. Finally, it may be useful to develop a set of composite indicators that could look at different elements of MNH data use by different kinds of health workers or health managers, and combine that with qualitative information to provide a richer picture of the construct. I was also asked to see or attempt to try to operationalize this indicator or the original draft indicator in a little bit more specific way. And so I've made an attempt here to really hone in on maternal health. And so I have tried to show here the level of specificity that would really be needed to operationalize an indicator for this construct. And what I've proposed here is the percent of maternity care providers who can provide a specific example of using routine labor and delivery data to inform a management decision at their health facility in the specified time period. So in terms of presenting the definition, I've made an attempt here to define the different terms that would need to be clarified. Proposing the data source as either some kind of supportive supervision monitoring tool or periodic interviews with health providers in the maternity area. And the potential users would be facility-based healthcare workers, either providers or managers at the health facility level, and district health managers. Not really clear that this would be a meaningful indicator at the national level, though. So thank you very much for your attention, and I look forward to engaging with you all and discussing this construct further and deciding if it should really move forward in terms of work on operational definitions. Thanks.